another episode of Well-Adjusted Mama. I'm your host, Dr. Laura Brayton, and today's guest is Niva Herzig, speaking on pelvic floor muscle dysfunction. Niva is the owner and director of Core Dynamics Physical Therapy in Englewood, New Jersey. Niva received her Bachelor of Science from George Washington University in 1996 and her Master of Science in Physical Therapy from Thomas Jefferson University in 2003. Niva has written several articles related to pregnancy and also to pelvic floor muscle dysfunction. She has had the opportunity to assist in several pelvic floor muscle dysfunction and pregnancy courses, as well as be a speaker for grand rounds in other groups. Niva has received her Biofeedback certification from the Biofeedback Institute of America. In 2012, she became a certified myofascial trigger point therapist. Niva has also attended abundant courses and conferences on pelvic floor muscle dysfunction and is always eager to continue her education. She is a proud member of the section of Women's Health of the American Physical Therapy Association, as well as other associations. In November 2007, she proudly opened the doors to Core Dynamics Physical Therapy, a pelvic floor clinic. Niva, originally from Israel, grew up in the suburbs of Philadelphia. She is fluent in Hebrew and English and currently resides in Bergen County with her husband and children. She enjoys being outdoors and active. For more information, you can find her at her website, coredynamicspt.com. Welcome, Niva.
Thank you. So
I'm excited to have you here today. Yeah, to share, your wisdom. We've been known each other for years through having similar patients in common, and since your practice is not too far away from me, and you have a lot to offer women regarding restoring pelvic floor and really educating and empowering women of why this is so important. So if you could just start off by sharing what is your personal story of why you chose to specialize in treating pelvic floor muscle dysfunction.
So my personal story is not because I was a patient, but more just this long history of being intrigued with pregnant women and watching just women when I was younger being pregnant and being fascinated about our bodies in that way. And this was just way before I even had children and thought about children. I went into college thinking med school and a career possibly in OBGYN, but I just started getting away from that towards the end of my bachelor's degree. I went back home to Philadelphia and started thinking what else I could do. I was really intrigued by healthcare. And I took some anatomy courses. I myself started exercising. I had my own physical therapy after a car accident. And I decided I'll apply to physical therapy school. And once I was there, I was lucky enough in my third year to be able to do a research project that focused on physical therapy for pregnancy and postpartum. So now I knew this interest that I've always had was a possibility in my future career. And then I even was more introduced to pelvic floor. There was one clinical, as a student, available in a pelvic floor clinic outside of Philadelphia, and I grabbed it. No one at the time wanted it. I was very nervous. Nobody take it. So I had the experience as a student. And after that, I moved to New York City, and I started looking for a career at a clinic, and I was hired somewhere in the city, which was also just focused on pelvic floor. So I went into a focus of I wanted to see pregnant women, but all of a sudden I learned about pelvic floor pain, and that was really growing at the time. And so I've been doing this since 2004, and thank goodness, still loving it. And, you learn all the time, and it's really rewarding. It's been a small community of physical therapists. It has definitely grown, which is great for all those out there, but there's just so much more to learn and to educate both the patients and our healthcare systems. And I've been doing it for 10 years.
Yeah, I think it's such a valid point. You mentioned that not all physical therapists have this specialized training. And at this point, it's kind of a small subset of your profession, but it's such a valuable and important one, especially for our listeners today who may be pregnant or who have recently given birth and are, struggling with some issues in that pelvic floor area.
Yeah, and it's great at this point. It's funny and it's great. The sadness is not all physical therapists actually know that there are pelvic floor physical therapists. But there are other therapists out there that are not treating but know this exists and know when they get stuck that they think, okay, this actually might be one of those pelvic floor issues as well, and they know to refer out as well. So we can really work together even within the physical therapy community if one doesn't work with pelvic floor. Right.
And, referrals are so valuable. Like, as a maternity chiropractor, I work on the pelvis and helping to correct alignment and preparing for birth, but certainly strengthening certain muscles or releasing certain muscles can really benefit from a referral to a pelvic floor physical therapist. So I love bringing these modalities together. So if you could just explain
multidisciplinary.
Oh, yeah, it's working holistically. If you could just explain to women listening, what is pelvic floor muscle dysfunction, kind of describe what it is, what are some of the causes, and then we can get into treatment.
Okay, so pelvic floor dysfunction occurs when the muscles of the pelvic floor are in a state of increased tone. They may be hypertonic or they may be in spasm. Or they may be too lax and have low tone or hypotonic. We can see this as one or the other or a combination of both. So there are several muscles that make up the pelvic floor, and you might have one that has too much tone, but on another side or another place in that pelvic floor, another one could be too loose. So we really examine by a manual examination and palpate all those muscles and find what's going on. So it's not just one or the other. The definition could be a too much tone or too low tone. Most likely the ones with too high tone and spasmic muscles, it's a pain case. And those that have low and laxity, we usually see weakness. Weakness actually could fall on both, but weakness and prolapse and incontinence issues. And what's the cause? So I will admit I have many patients that come in to me and say they don't know. But taking a really good thorough history, eventually we find something. In many cases, I have to say, I almost call it like a bad soup or stew. They start giving me all these ingredients, and I just tell them, at one point it just overflowed. If that makes sense. But for sure you can have injury. You can have an actual trauma like falling, horseback riding, avid cyclists. I've seen patients post-childbirth with an injury at that point. There is some commonality to a history of sexual abuse. Also constipation, severe constipation, and prolapses. Another common story I get that I filter through that this is why it happened is women come in with years of history of infections, whether urinary or yeast infections. And then there's definitely some relationship to orthopedic cases, to some of the hip and spine disorders we see these days. And on the other hand, medical diagnoses such as interstitial cystitis, vulvodynia, pudendal neuralgia, diastasis rectus abdominis, the pelvic organ prolapse again, and urinary and fecal incontinence, we find those that the person has a pelvic floor dysfunction, also endometriosis. So every person is kind of different, but those are the most common ways I would say the causes.
Yeah, I mean, that makes all sense. There's some sort of trauma or infection, always, the physical stresses, the chemical stresses, and then the emotional stress. I mean, there can definitely be an emotional component as well to that dysfunction.
Sure, and I talk about it later on when we talk about a treatment, people get also into a fear avoidance. Even I see them as I treat them, and they know they're getting better. I know they're getting better, but they fear even going back to the activity that may cause their pain.
Wow.
But emotional is definitely part of it. Living in pain every day is can be draining to anybody.
Yeah.
It's difficult,
right.
And it's a difficult place to go and enter any healthcare office, and right away you're asked, what's wrong, and you say pain, and there's a lot of fear from our healthcare community of, oh no, there's somebody in pain. So they get kind of pushed into the corner. A lot of people don't want to deal with people that have pain, and it's sad.
That is sad. And then you had mentioned the sexual abuse, which can create physical trauma, but certainly emotional trauma as well that gets stored in that part of the body. So, this work is so important.
It's on.
So,
it's on
if a woman is
history question.
Yeah, if a woman is, having issues like you mentioned, the urinary incontinence or some sort of prolapse, and is suspecting or is diagnosed with this pelvic floor muscle dysfunction, what can she do to heal?
So treatment-wise, you're referring to?
Mm-hmm. Yeah.
Yeah. So
in the office as well as at home.
Oh, okay. So before I send anybody with home programs, I want to check them out, obviously. In the office, I'm more of a hands-on therapist. We like manual therapy. We use techniques such as myofascial and soft tissue release, connective tissue manipulation. We really focus on the pelvic pain side, on the 2-10 side of opening up tissues, really gaining circulation, some oxygen in the tissues, healing the tissue. We do work with trigger point release, and as you had mentioned before, I do use some dry needling myself. We put a program with neuromuscular reeducation, which can consist of breathing exercises, mindfulness, really getting the people to be aware of the muscles. That's really one of the first things, is getting that awareness and coordination. This is not only because of their pelvic floor dysfunction, but just because it's a part that we just don't really recognize day to day. We don't really talk about the pelvic floor, with anybody. So I really try to get them to connect. One of the ways I can get them to connect is also through biofeedback, which is a tool I use that they can monitor their muscle activity. So I'll use that for somebody to increase recruitment, uptrain their muscles, or to downtrain, to show them how to let go of those muscles. Of course, we put exercise programs, whether it's stretching or actually strengthening. And then we'll use some orthopedic tools, joint mobilization, muscle energy techniques, anything like that. And for home, I will teach patients how to do some self-release. On the outside, they can do their own connective tissue, we call skin rolling. We can teach them how to do, I use myofascial balls and things like that they can actually do some release on their tissues. A stretching program for home, and then a strengthening program as well. Everybody needs to learn how to contract their pelvic floor muscles and how to lengthen and let them go. That's huge. The muscles are going in that motion all day long, so if they're stuck one way or the other, there's going to be a problem. So they have to know both ways. Breathing, as I mentioned before, is definitely important for many reasons. One, for helping them desensitize and calm the body, but also, as I said, the awareness of the pelvic floor, because you can very much coordinate the pelvic floor with breathing. And then an individualized exercise program when it's ready.
Mm-hmm. Yeah, and it sounds like it's so powerful to show a woman who's, getting treatment in your practice of what she can do at home to help the healing process, help strengthen, help her recover faster? And a lot of it's probably awareness. Right. Is there also anything related to avoiding, like lifting heavy items?
Oh, yeah, sure. Biomechanics and posture.
Stuff? Yeah.
Right. So biomechanics, posture, any of that has to be reviewed. I mean, I don't expect everybody to be, perfect posture all day long. I mean, I can barely do that. But there's definitely the right place and the right time. I'll even talk to women about crossing their legs, when to do it, when not to do it. And for sure, this is very common these days of how they actually do injury, maybe how the cause, how it does occur is exercise programs, and people incorrectly exercising. And, these patients aren't, I don't treat anybody like a cookbook. When they come in, it's really individualized. So they may start telling me about one thing, and then I say, oh, wait a minute, you just talked about an exercise class. Like, I want to see what you do. And, I don't want to scare them, but often I really, you find somebody that they're not doing it the right way. And it's not their fault. It's not the gym class's fault. It's just the way they've learned to do something. So I really work with them either to hold off on it for that point, or if they're ready to then proceed, but the right way, obviously. Breath holding. Like, everybody holds their breath when they exercise and when they do pelvic floor exercises. It's amazing. But we need to breathe.
Yes, we do. So important.
Breathe.
So that's such great awareness. Like, I mean, literally just showing a woman how to breathe while she's exercising and how to exercise properly can make such a big difference in her recovery. Yeah,
and it's amazing because I sometimes, I catch myself and I'm speaking to somebody and I'm, patient, and I feel like, don't you know this? And no, people don't know this. It's not something they thought about. And especially when you connect it to the pelvic floor, like I said, there's a huge disconnect.
Yeah.
The other thing we work on is scars. It's making me think of that. So women that come in, whether they tell me or are complaining about like a C-section scar, I go and look at it. I love scars. I want to work on them. And they say, why are you touching that? I haven't been there in 20 years since my kid was born. I mean, you have to connect to your body.
Yeah. Right. And sadly, I think in our culture, there is such a disconnect of women from that part of their body. It's like, an area that we kind of avoid. We don't want to talk about it. We don't want to go there. But it is important to be familiar. Yeah.
It's scary. It's painful. Yeah.
I was hoping you could maybe walk us through a woman showing up to your office. Like, you mentioned the techniques that you do in office, and it's hands-on, but can you just go into a little bit more detail? Like, there's some internal work, there's external work. Like, can you also maybe describe a little more about what the biofeedback is like?
Yeah, of course. It's a great point, because I actually feel that sometimes people don't come into therapy because they don't know what to expect. So I definitely appreciate that question. So anybody that comes in is getting, obviously, a thorough history. We sit down and go over medical history, surgical pregnancy, the usual stuff, really hear their story. These patients really need to be listened to. And it's amazing what you get. I mean, I can start pretty much assuming what I'm going to find based on their story. I'll look at their posture and standing, sitting. I'll look at alignment, especially of the pelvis, some range of motion, strength of the external world, the legs, the spine, anything that's appropriate in that case, the hips, rule any of the other injuries. If I've ruled all that out, then I'll for sure jump into then assessing pelvic floor. Sometimes when I do find some other orthopedic issues like their hips or sacroiliac joint, something like that, I may look at that first because I can get some relief for the pelvic floor without even touching it. And then assessing the pelvic floor, the patient does have to undress. It's a manual exam as well. So I don't use a speculum. I don't use stirrups in my office. Obviously very sterile and clean though. And I do a single-digit vaginal examination or rectal, depending on the person, palpating the pelvic floor muscles, palpating around the uterus, bladder, just to get a feeling of everything. And then I feel for what's going on. I look for restrictions or, like I said, too much laxity. And I will assess their contraction, so they'll have to contract, and I'll more importantly assess their relaxation and how they can then bulge or lengthen after that relaxation. So I'm looking at that flexibility of the pelvic floor, but also the coordination in that sense. I mean, they don't even know, but I am looking at their breathing at the time. I look to see, and I feel around the abdomen, seeing the coordination of what's going on between the abdomen and the pelvic floor and the breathing. I assess all my patients also in the abdomen for other restrictions and for the diastasis, for sure, if they're postpartum. And also before I do an internal pelvic floor, I'll look at the external. So there's 3 layers that I really look at, and the first layer is pretty much external, so there's a palpation of the perineum and the muscles under the labia going all the way up to the clitoris. If I have to, I can do any neural examination as well. But it's as much as possible in a pain-free state. I mean, it's not meant to provoke anything. So if somebody comes in and they have very brittle tissue and they're already telling me that they have tears and bleeding, again, I may not jump into something internal right away.
Wow.
And based on, what you find at that point, I take it into a treatment.
Right. So, if you could just elaborate a little more about how you utilize biofeedback, what is it and how it's used in your practice? Okay.
So biofeedback is a monitoring system. It's a way we can learn. So I'll give you an example. Besides the machine of biofeedback, a mirror could give you biofeedback, and I use that too. So we can watch. I can actually have somebody hold on a mirror and put it so they can see the vagina and see the external genitalia, and I can, let's say, have them contract their muscles so they can get feedback. So biofeedback machine, I'm either using an external electrodes, and I place them outside of the pelvic floor, so they're right outside the anus and perineum. I usually stick them on there. And it's non-painful. It's just like having a Band-Aid on you. And the machine reads muscle activity, so it'll give them a number, or you can see it on a graph, and they'll see what their resting tone is, and I'll see. And if they, let's say, contract their muscles, we'll see those numbers going up. If they relax, we'll see them going down. I'll use it for sure in a strengthening, like somebody who has incontinence due to weakness only, and we do exercise programs. I can set mine up to do different types of repetitions and, hold for 3 seconds or hold for 5 seconds. But again, I individualize that. I don't like the, just hold them for 10 seconds, do it 10 times. Every person is really different, and that's based on my manual exam. When I examine them, I really see how well they hold, how long, how many times. That's how I really assess their strength and their endurance. So as they're doing that, the biofeedback machine can be set up to make some sounds, or like I said, they could see the graph moving. So they know if they can't really feel or tell that the pelvic floor muscles are contracting and relaxing, they're getting that feedback from the monitor or from the auditory sound. And so those are with the external. There's also an internal sensor that can be used either vaginally or rectally, depending on the person.
That's really cool too. So it's giving the person more information, and it also looks like a great way to gauge progress. So from session to session, they can see that their muscles are getting stronger, or their muscles are learning how to relax when appropriate, and that can be exciting to see that as well.
And I can put them in different positions, Initially, they're laying down for an exercise program. Then they might be standing with it, It's movable, so we can do whatever we really want with it. Going back to the breathing, somebody that, is very coordinated with their breathing, the pelvic floor, I can just have them sit there and breathe. And I can watch what happens on the monitor. So if they inhale and those numbers are shooting up, I know something's wrong because the muscle should be relaxing. So it's great. Somebody that when I turn on the machine and the resting tone is higher than what's considered basically the norm, I know we need to do some down training before we do the contractions all the time. So it is great feedback. And after a certain amount of strength, I try to wean them off of the biofeedback.
Mm-hmm. Yeah, it sounds like it's for maybe a woman who's just not familiar with that part of her body, who's been so disconnected. It's just a way to kind of reintroduce, get things, get that awareness there, and then she can do it without the machine.
Right, and I've set women up with there's some home biofeedbacks that people can rent and buy, so they can go home and do that. The other nice thing about biofeedback for, let's say, some of the women that are having painful intercourse or suffering with dyspareunia, I can again put them on the biofeedback, and as I do my examination, or we'll use something like a dilator, they'll see what's going on with the muscles, and they'll see them. Am I guarding? Is it naturally like that? Have I already habituated to that? Can I let go as we are doing the treatment? So it does give great feedback.
Another thing that's coming up for like a woman listening perhaps who is currently pregnant and wanting to prevent having issues during the pregnancy or after the birth. Do you have any suggestions for her of what she can do preventively?
For generally for postpartum, prenatal postpartum we're talking about?
Yeah.
Okay. So if she's presenting already with any, let's say, bladder issues, I'm definitely going to go into a program of good bladder health, and that could be for before and after. I advise during pregnancy how not to injure themselves. I will like to teach the pregnant patient, even if she's coming in for low back pain, let's say, I will talk about how to use the pelvic floor, because I think in the long run, obviously, that's going to help her no matter what.
Right.
So if she allows for it, I will show her what is a contraction, and again, important for her, what's relaxation? She needs to let go during childbirth, during labor.
Right.
Other things is let them be aware that postpartum, the body has changed, and we really just need to learn to adjust to that new body. It's not, the center of gravity is a little different than what it was when you were pregnant, and how to really appropriately return to exercise programs. I know there's some great fitness instructors around here that have taken courses with for prenatal and postpartum women, which is so useful, because I don't want to hear them coming in saying, I injured myself, I went in too early. I want to check their abdomen if they do have that separation in the abdominal muscles. I want them to learn how to work on their scars if they had a C-section, or even more importantly, if they had an episiotomy or any tearing. because unfortunately the system is we don't go in until 6 weeks post delivery, and we can already in those first 6 weeks be doing something to prevent any further issues or any issues at all. And really, 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 really to just educate that, leaking and having painful sex postpartum, that's not normal.
Right.
We can do something about that. And we don't have to be scared to talk to somebody about it. And we can find, if we don't know somebody that we can discuss this with, we can find somebody to discuss it with. So I really think that, a lot of people think, oh, I had a baby, or I'm told, oh, you had a baby, or you're having a baby, that's normal. Oh, you sneeze and you're leaking, like that's normal. I mean, we see it, so I guess in that way you can say it's normal, but it's not normal. It's not
common,
something that we should have. And it is,
right.
It is fixable for many cases.
Could you elaborate? I think that's so valuable for women to hear this. And, you mentioned things like work that a woman can do that first 6 weeks postpartum to help with the healing of scars, whether it was a surgical birth or just episiotomy, and good bladder health. Can you be a little more specific what you mean by that?
So with the scars, C-section scar or I guess any scar actually could be, it depends on how it's healing. But we could put warm compresses, maybe some oil, so just to do some skin healing in general. I'll teach them how to massage around the scar if they can't get onto the scar, and then later on the scar as well. Some women you can use even
recommend like coconut oil or any
coconut oil, almond oil. Those are usually my safe ones. For both pelvic and abdominal. So yeah, I love those both. I have them both in my office. So I use those for scars. Because I usually can't get an okay from a physician until 6 weeks, I may wait then I'll wait for the dilator until 6 weeks, or an internal, unless I get an okay for it. I also will stay away from doing anything internal for 6 weeks. Also they're most likely still bleeding, so it depends on that, but it depends on what, that is an okay from a physician. But they can do massage, and that is something, if they come in prenatal, I will talk about perineal massage and using the coconut oil or the almond oil before delivery or after delivery for those other reasons. You don't want that scar tissue to heal in a more random way and bunch up perhaps and just cause pain that shouldn't, that can be avoided.
I love how you just mentioned doing that perineal massage during pregnancy. That's probably one way to help support pelvic floor health and certainly help ease your labor and delivery and perhaps prevent tearing if it's a vaginal delivery. So this is, really, these are things that tools that women can use. Would you recommend that daily? What would you say?
It depends on the person and, but they can do it once a day, even for a minute or two. I'll have them do it. If not, a few times during the week is fine as well. Just
that stretching, that opening, because certainly that's important.
Yeah, I'll have them massage from the outside if they're scared to put anything inside. Then they can also, talk about biofeedback. They can feel, with the breathing, with the gentle bulging, they can feel that letting go. So they'll know, they'll get feedback onto their fingers as they're doing the massage. So they'll know, oh, I'm opening up. Oh, no, I'm tightening. It's a great feedback for them.
Yeah, because
and even more, they can do it in different positions.
Okay. And this is during pregnancy, kind of just getting more familiar with the birth canal, essentially. And, I have seen women that, were did tons of exercise pre-pregnancy, during the pregnancy, and their pelvic floor was so tight it did not know how to relax, and it created a lot of issues during the birth. So learning that relaxation is just as important as the contraction. They're both so important.
Yeah, and even in pregnancy, very much so. I know there's I've spoken to some GYNs that really didn't want any pelvic floor exercises or Kegels to be done during pregnancy because they were scared that the person would lose that letting go awareness. And, I would agree with them, but I at least, doing that with the appropriate physical therapist, will teach them both ways for sure. But very important.
Reminded me of something else. What is your opinion on Kegels?
There's a right place and a right time.
Okay. Can you be a little more specific?
Kegels are good. I can probably go to Times Square and pick out 50 people and get at least half of them that are doing them, and these are non-symptomatic people that are doing them incorrectly. For somebody who is truly weak and knows how to relax their pelvic floor, I use them. That somebody that's coming into me with that spasming and hypertonic pelvic floor, it's not where I'm starting. Even though they may present weak because of that, it's definitely not where I'm starting. So that's why I say there's a right place and the right time. And like I said before, it's not, you could do 10 seconds, 10 repetitions. No. It's really individualized. Some people could do that, but some people can't.
Right, and that woman I've seen this even like a woman having urinary incontinence postpartum, there is obviously weakness, but in her case, her pelvic floor was just in this constant spasm, and it was creating this urgency to have to urinate all the time. And so in her case, Kegels are going to make that problem worse. Like, she's got to learn how to relax and let those muscles go.
Right. Yeah.
So can you share a case study from your practice of successfully treating a woman with pelvic floor muscle dysfunction?
Okay. So can I do? I'll do a pelvic somebody with pain. I can do one with pain and one incontinence. Is that good?
Yeah, and maybe specifically prenatal, postnatal related, if possible.
So my the pelvic pain patient is a nice kind of both, I guess. I was seeing her several years ago, back in 2012. She was referred by she's nulliparous, never been pregnant, young female. Referred by the gynecologist with a history of vulvodynia, vestibulitis, and pelvic floor dysfunction. Her symptoms, she described them as sensation of tearing upon any penetration. It was sharp. She would also have some painful sitting. And she had a history of constipation, history of right hip pain, and some clicking and groin pain, and occasionally tailbone pain. When I examined her, she had a positive cotton swab test, so that was of the vestibule, and she had marked tension in her transverse perineal muscles, which are superficial. And during a pelvic floor examination, she did present with that high tone in several of those muscles, and was pretty tender. On a side note, she did have a history of sexual abuse, this person.
Okay. All right.
So I described her muscles as hypertonic, and they were shortened. She could not do that letting go. She started with dilators, and I did connective tissue manipulation on her, on the legs, on the thighs, on the groin area, all in the external genitalia. She worked with breathing, lower extremity stretching. I did do internal work. She was fine with it. I had to send her back and forth to a physician. She had some injections with the physician, and I was also doing some dry needling with her.
Injections of steroids?
She had Botox injections. With the physician, she had Botox to the pelvic floor muscles.
Okay.
And she was put on an estrogen testosterone oil as well for the vestibule. And she was also put on a Neurontin compounded cream to help with the nerve pain. I think it was, I'm sorry?
Psychotherapy?
Well, it was a compounded cream, so she was putting it at the vestibule, at the opening.
Yeah, I was curious if there was anything for the emotional component.
Oh, was she doing any She had in the past. I actually don't recall if she was seeing anybody at exact that same time, but she had been to therapy. And she had been to other physicians. She was told something else in the past, and then she was referred to me. I sent her on to a more specialist gynecologist to do some of those injections and the hormone balancing and everything. She did progress to a large dilator in several months, and so she came in within like 8 or so months. She also started a relationship. And they were not going to do anything premarital, but there was touching, there was foreplay. She was starting to tolerate that more and more, and she got married in July of 2013. And she was so nervous about consummating the marriage. She's like, I might email you that day. I remember that. But they were able to consummate the marriage. She said sometimes it was pain-free, sometimes it was without pain. I saw her a few times after that, and the doctor did look at that and decided she should have a hymenectomy. Her hymen was not completely broken, and that may have helped her. And she did actually after that have pain-free intercourse.
Oh.
And she was pregnant by February 2014, and now she has a baby. So she actually has, and she lives now in Brooklyn, and she does contact me every once in a while where she, I got to come in. I want you just to check everything. So we talk a little bit, email and things like that. But she's been good. But she got pregnant,
that's a cool
and that's
story.
And I've had several of those that it's the they know they want to get married one day, they want to have kids, they're scared, what am I going to do? And I kind of get to walk them to that. So I do get, I do get calls of, can I call you the night of, just cute. So yeah.
Did you hear about how the birth went for her? Like, do you know if she had any issues with it opening during the childbirth?
No. She didn't. She worked with, she did work with a doula. I remember that. Mm-hmm. No, nothing that made her run back to Jersey to see me. I mean, I would have offered to refer her to anybody. She's okay, and actually I haven't heard from her in a long time at this point. She sent pictures of the baby at one point. Unfortunately, I think sometimes, after having the baby, we kind of put ourselves on hold, but I think knowing how she did well with therapy, she would have come back in.
Yeah.
So she's a mommy now. Yeah, I'm very, very excited for those girls.
And you mentioned you have another story as well.
Yeah, so I pulled something out for a patient with incontinence. Who, when she came to see me, she's 59 years old. She's had some stress incontinence since childbirth, since her children, but her children are grown now. And this is that case of why are we waiting, 20 years? But basically what sent her to me was her gynecologist did send her to me, but she had stress incontinence that was worsening. So she was leaking with only urine, with coughing and sneezing, going down the stairs, and sometimes just even walking more than several blocks. And the past 3 years were really bad. And she finally, opened it up to the gynecologist, and he said, why don't you go try physical therapy before we talk about surgery, which I was so happy to hear when she said that.
Yeah.
When I assessed her pelvic floor vaginally, she was very weak. She was completely unaware and unconnected to the pelvic floor, both pelvic floor muscles and through the abdomen. She really just did not know how to contract and to relax by any means. Excuse me. And I tried to assess her when she would cough. I wanted to see what her muscles would do because they should contract, and they didn't. She wasn't able to do that. She didn't have that connection. So I really started working with her pretty slowly. It took us 3 or 4 visits just to get her to really more and more connect to the pelvic floor. I knew she had it in her somewhere. Sometimes it could sense it. She really is a case of weakness, but yet disconnection. So we worked on verbal cues of how she can get those pelvic floor muscles to recruit. I worked on her transverse abdominis. She was somebody that I did use biofeedback at every visit. I had her coordinate the pelvic floor and the transverse abdominis. She worked on breathing, and eventually we worked on functional exercises because she was coughing during the sneezing she was leaking during sneezing and coughing, and walking. So she would do exercises like step-ups where I would have her contract those muscles as she was doing the step-ups, or wall squats or side steps. So I actually only saw her 6 times, which is great. Mm-hmm. I would have liked to see her more, but she called me and she said she was really, she felt comfortable now doing the program on her own, and she was more aware of the muscles and how to contract them and how to use the breathing, and she was not going to pursue surgery at that point.
Yeah. Yeah, I love that. And it's like always, let's do the, least invasive first, which would be the physical therapy before, launching into surgery. I mean, I'm assuming you've even had cases of prolapse, let's say maybe a uterine or a bladder prolapse that you've been able to help heal, and that woman's been able to avoid surgery.
Oh, yeah. And we occasionally will get a referral even during pregnancy, or about with somebody with a prolapse. So we'll use biofeedback on them. What I do say to the women with the prolapse is I'm not going to necessarily, I'm not surgery. I'm not lifting your bladder. I'm not lifting, so we're not going to get to that. I don't want them to think that I am, moving it. But I definitely can say that we've reduced the intensity and by all means increased their strength. Those patients, going back to like the bowel and bladder habits, have to learn how not to push and really how to use their muscles during toileting so much better. And they have to know what the right exercise program for them, for them to be doing like jackknifing exercises where their legs are up in the air and their head's up in the air, and they're doing abdominal exercises, but yet they're very much pushing down on the prolapse. So it's also an awareness program with them. But yes, there's been
and I mean, I'm even thinking of like women that get hemorrhoids during, pregnancy or, during the birth. Like that's also regarding, how things are being used in that area. Mm-hmm. So perhaps like squatting instead of sitting on a toilet, right, could help.
Right. And not straining and maintaining a good bowel habit, breathing correctly, using the abdominals correctly during toileting. Mm-hmm. They're all things that can be worked on with these women. I mean, listen, if it were me and I was offered surgery or try something like this, for sure.
Oh, yeah.
It's non-invasive.
Right.
I think, there is a right place and time exactly also for surgery, but I wish. If only I could get every woman, for sure prenatal and postpartum at least once, just to get assessed. Once we get that, something like that, or have one visit before, surgery just to see, you never know.
Yeah, and even potentially, if the doctor's saying you need surgery, just trying a course of physical therapy with a certified therapist and see if you get a response, because it's hard to even tell sometimes in a session. And at the end of the day, surgery can wait. And in a case like that, it's not life threatening. And then if you're not responding to the therapy, that's where surgery comes into play.
Sometimes we have to try generic medicine before it becomes the brand name medicine, or we have to have an X-ray before we have to have an MRI. Why not have, some physical therapy, chiropractic therapy, acupuncture before we do, X, Y, and Z? That's more costly, more invasive, more recovery time. Mm-hmm. I have no problem admitting, it's not, it's not for you, it's not working, but it's a much, I think, safer way and more proactive and really where we should be in healthcare.
Yeah.
At least
there's no doubt. And even, recently I see on TV commercials for the mesh, for women that have had prolapses, bladder prolapse. And, there's some really serious side effects that have occurred with those types of surgeries. So, it's unfortunate that, maybe those women didn't even know that therapy could have been an option for them.
Yeah, no, I don't think many know. I really do. And listen, I know that. They come into my office, and sometimes they come in really on their own. They find us on their own. And, like I said, I ask for the history, so I hear that they've seen other providers, and they're not being referred.
So if a woman is suspecting that she might have issues in that area or has some of the symptoms you mentioned, what is the best way for her to find a physical therapist who is specifically trained in the pelvic floor?
Yeah, so there are some organizations, associations, one being the American Physical Therapy Association has a section for women's health, and we have our own website. We also treat, many of us treat men as well, so at this point it's women's and men's health, but there are directories on that website. Other organizations like International Pelvic Pain Society and the National Vulvodynia Association, I believe they both have directories for providers, meaning either, PTs or MDs, anybody can do that. And obviously we are living the world of social media. So there's a lot of Facebook and Twitter and Instagram. There's, PTs are there. I have a Facebook page, got to do it these days. And websites, doing a search, doing even a Google search. There are a lot of support forums. I do warn some patients about it. You can have misleading information, and they're not necessarily monitored by the providers. They're patient monitored, but they're also out there. I've held support groups at my office for people with pelvic pain, just so people know they can go somewhere and be with others that are like them. Most
that they're not alone.
That they're the only one.
Help. Yeah.
Yeah, they really, as much as people know I'm a pelvic floor clinic, whether it's for the incontinence or for the pain, any of that, each one that comes in and say, do you know others that are like me? And I look at them like, yes, this is what I do all day long.
Yeah.
And they're in shock. So there is. There is ways to find us.
And I think it's just so important.
And luckily, we know each other. It's a referral.
Yeah. One last point that I wanted to cover is if a woman, and you kind of covered this with the one case study you mentioned of the 59-year-old woman, if a woman does not address this issue, let's say postpartum, where she has weakness in her pelvic floor or in her abdominal wall, you mentioned that one case of the incontinence that occurred, 20 plus years later, and also prolapse. I mean, this is something that even if there's not a lot of symptoms at that time of giving birth, it can develop over time. So that's another big reason why it's important to address it ideally, when the trauma occurred, so to speak.
Sure. I mean, I've seen women that come in immediately postpartum and they have a prolapse from that delivery. And I see women that are coming in 50s, 60s. They say they may have had a mild one that didn't interfere, and after one child, after the first child, but it was with other children, or now they just had, did different daily activities or started, kickboxing or something, and all of a sudden they realized that organ is just not where it was before. So it could, over time, exacerbate.
Yeah.
And they really are uncomfortable. Those women also are very uncomfortable. Mm-hmm. They feel pressure, and they do recognize that something is not in the right place.
Yeah. Awesome. Well, I am so thankful for you to take the time to come on and share your wisdom with our listeners. And, thank you for all the work that you do for women's health.
Thank you, and thank you. And I really want people to get early care. I hopefully will get to a point that we're not misdiagnosing or missing what could help some of these patients and really getting them to the right place. And I think we can all agree that delaying the treatment can just make it worse or start new symptoms as well, just exacerbate what's already there. So I really hope we can get to that one day, that this is just a general routine visit, just to get checked up and,
Yeah, I think it would be wonderful for that to happen for all women. So let's continue to get the message spread and for women to know that, even if their doctor isn't specifically making that referral, that, specialists are available, and they don't need a referral to come to your office. They can come on their own, like you mentioned.
Yes, there is direct access, and I don't want to go into the insurance aspect of all that. Some will have to have, and obviously if they're not getting better, they have to be sent to physicians. But usually most of our patients, even if they found us on their own, they probably have seen somebody, so we know they've been checked out. It just, this was not known to whoever was checking them. But
All right. Well, thanks again for coming on.